We are very fortunate and honored to have Dr. NSD Raju sir as our keynote speaker. He'll be speaking about updates in neuro-ophthalmology. He's a past president of All India Ophthalmology Society and International Manual SICS. He's a director of NSD Raju Eye Clinic and Research Center. He's a comprehensive ophthalmologist with keen interest in neuro-ophthalmology. I welcome you, sir. Please come. So we'll start with the topic, Updates in Neuro-Ophthalmology by NSD Raju, sir. And the discussion and the queries, we can keep it to the end of the talks.
Thank you, Chairman Dr. Hannah. Now to begin with, express my gratitude to the Kerala State Ophthalmological Society and also the chairman of this important session, Dr. Hannah, for inviting me to participate in this very important topic and instructor course on neuro-ophthalmology. And as you know that there have been tremendous advances in the field of neuro-ophthalmology during the past 5 to 10 years, and it's not possible for one to traverse through all the newer developments, and also because of the time constraint, because I have to finish my talk in 8 minutes. So I'll try my first. You know that so what we will do is I will pass from the globe, the retina, to the optic nerve and the visual pathway and come back to the eyeball again with the pupil and also the ocular motility disorders. So what you see there is acute retinal ischemia. As you know, that the blood supply to the eye and the brain, the anterior part of the brain, are the common source of anterior cerebral circulation. So whatever changes that you see in the retina reflects itself in the brain also. That's an important point. So let us see what are the acute retinal ischemia conditions that we come across in our daily practice. Of course, the acute ophthalmic artery occlusion. Do you have the point? This is ophthalmic artery occlusion, this is central retinal artery occlusion, and here you have the branch vein occlusion. And there are some cases wherein you get the transient monocular obscuration of vision. All these are the visual outcome in all these are the different forms. All of them may not have the same visual outcome at the end of the treatment, but the systemic implications are the same. That is the most important thing. Let us see what are the systemic implications. You will find that if you take the DWMRI in these cases, you will find there are white lesions, active lesions in the white matter. You see that in about 53% of CRIO, 35, 18, respectively of TML have these lesions in the cerebrum. So that indicates these are microinfarcts, so they have the same sort of inflammation, occlusion in the brain as well. So we need to do, that is a newer thing now, perform DWMRI within 24 to 48 hours. So any patient with an acute retinal ischemia, immediate referral to the stroke neurologist. That is one thing, but take-home message that we have. And likewise, there are chronic retinal vascular changes like this AV nipping, this copper wiring, and attenuates the vessels. These are all chronic retinal vascular changes. They also indicate that they may be, in due course, be associated with strokes and restrokes, dementia, peripheral vascular diseases, cerebrovascular disease and severe deaths, and even chronic kidney disease. So how to know that which one is going to have which complication? For that, you have to there have been longitudinal studies which shows these things can occur. But when you have a case with this presentation, how do we know that in that particular case, which complication is going to occur? There we have the advantage of artificial intelligence and deep learning. This is a newer development in the field of artificial intelligence. Deep learning devices can categorize these findings and point and come out with a diagnosis and management system by saying that this is going to have cerebral stroke or it's going to have a renal failure. It's possible for us to do that. Otherwise, longitudinal studies only shows a general form of the developments and complications, not pertaining to a particular patient. Now, that is important thing we need to remember. Now, from the retina, we go to the optic nerve, The optic neuropathies, as a general rule, have the following things, which I am not going to repeat. Everybody knows that. Because of the time constraint, I am not going to describe the details. Of course, papilledema is one factor, is an optic neuropathy where the swelling of the disc, it is due to the increase in the ICP. It can occur in any age, it is painless, and it usually spares visual acuity, but it may produce a peripheral constriction of the field. That is one feature that everyone of us know. And there is another condition called idiopathic intracranial hypertension. It used to be a diagnosis of exclusion, but not now. The recent thing is that there should be the following, that there should be an isolated increased ICP, headaches, diplopia due to the involvement of the sixth nerve, and papilledema. MRI shows no intracranial lesions, and there are no signs of intravenous, venous sinus thrombosis. The CSF will be always above, the opening pressure will be 25 centimeters or more in adults and much less in children. So these are the other features. The so-called Dandy's criteria for IIH has been now modified, and let us see what are those things. And it contains almost all these features may not be present in a particular given case. Some of them may be, we have seen intracranial hypertension without evidence of papilledema, but that doesn't rule out the diagnosis. It is a diagnosis of certain findings together. Not all things may be present in one patient. And how do we predict the prognosis of these things? How do you treat it? The best thing is that the serial LP is not to be done. It is against the accepted norms of treating the IIT. The second most important thing is adequate dose of acetazolamide. We have to give adequate dose, up to 4 grams per day. We know that there are no serious common side effects. It may cause extremely rare complications like plastic anemia, but most thing is the tingling and other things which we can take care of. Other most important thing, take-home message is that if you ensure 10% of weight reduction, these are obese patients, we know. If she has 100 kg, if you can reduce it to 90, this process can be reversed. That is a very important thing. We must ensure there is weight reduction in the patient along with the treatment. And sometimes, in spite of all this, headache may persist, in which case we probably will have to take the opinion of a competent neurologist. How do we follow up these patients? The fields and the fundus serial examinations are the important things. If we do not respond, then only you consider about the surgery, like the optic nerve fenestration, CSF shunting, whether it is a ventricular or peritoneal, or stent of the transverse sinus. So these are the newer techniques with which we can deal refractive IIS in spite of adequate medical treatment. Now we go on to the optic neuritis. The most common variety we are worried about is the MS-related optic neuritis. I am not going into the details of the demographic pattern and the clinical presentation, we all know. And we also know that it responds to IV steroids followed by a steroid taper. And treated and untreated cases ultimately will have the same visual recovery, whether they have treated or not, at the end of 6 months. So initial treatment with the steroid alone is contraindicated because it is associated with the incidence of MS in these patients. That is another. I may not be able to complete my talk. Can I have 2 more minutes? I told you it's only 8 minutes. Francis is smiling because he knows all the update information on neuro-ophthalmology cannot be completed even in 1 hour. So I have to do that in 8 minutes. That is a Herculean task. I will try. I am not repeating those things that are ONTT and also well known. I am worried about the 2 new sets of optic neuritis which is associated with serum antibodies. One is the aqua P4, RajuD1, which is associated with the NMO and NMO spectrum disorders. So we can categorize these into, in all patients with optic neuritis, you should take an aqua P4 serological test. That is one important point. Because the treatment may be different. Because these NMO patients should have, of course, have a steroid course along with plasmapheresis, and note the other type of treatment wherein give it to the MS-related optic neuropathy. Second one is a MOG. Some patients may be aqua P4 A negative, but still they have the optic neuritis. You do the MOG, the MOG antibodies. So if that is positive, it is an MOG antibody positive. It's a cell-based assay, and you have to treat that also in a different pattern. It can occur in the adult and also in the children. In children, it causes what is called ADM. I know that it is an acute multifocal encephalomyelopathy, so that responds well to steroids and they do well. So the pattern of treatment had been differentiated and selected depending upon the serological results also. That is one more important newer development that has come in the things. I don't think I will go into the other aspects of these things. There are so many. I think we will have a discussion on this on another occasion. I would like to inform you that we have an international neurological update session on neurological, neuro-ophthalmology session in Cochin on the 21st and 22nd, where internationally famed ophthalmologists from abroad countries and Indian ophthalmologists, and of course Kerala ophthalmologist. Francis is smiling because he is going to give a guest lecture on that occasion also. So I take this opportunity to invite you all to attend that session. So whatever has been left out, we can repeat there. We can have another session.